My name is Dr. Mark Litzow. I'm a professor of medicine in the Division of Hematology at the Mayo Clinic in Rochester, Minnesota, in the United States. And I'm pleased to present the results of the National Clinical Trials Network intergroup study E1910, which is conducted here in the United States, Canada, and Israel, looking at the role of blinatumomab in consolidation therapy for patients with B-lineage acute lymphoblastic leukemia who were in an MRD-negative complete remission. So this trial gave patients between the ages of 30 and 70 modified BFM type induction chemotherapy regimen for 2.5 months. This was based on a prior ECOG trial that we did, E2993, in conduction with collaboration with our colleagues in the Great Britain. Patients who achieved a conventional morphologic complete remission or complete remission with incomplete count recovery then got an intensification for CNS prophylaxis with high-dose methotrexate and pegosparaginase. Following this, repeat bone marrow biopsy was done. If they were MRD negative and in continued remission at that point, they were randomized to either get 4 cycles of conventional consolidation chemotherapy or that same 4 cycles of consolidation chemotherapy along with 4 cycles of blinatumomab. Blinatumomab, you'll recall, is a bispecific T-cell engager molecule that combines in a variable region of a CD3 antibody linked to a variable region of a CD19 antibody, and this is given by a continuous infusion for 4 weeks. So patients who were randomized to the blinatumomab plus chemotherapy arm got 2 cycles of blinatumomab, then 3 cycles of the chemotherapy, then another cycle of blinatumomab, another cycle of chemotherapy, the 4th cycle, and then the last cycle of blinatumomab. They then proceeded to maintenance therapy, which was timed from the start of that intensification cycle for 2.5 years. Patients could go off to an allogeneic bone marrow transplant with any donor, any conditioning regimen at the discretion of the treating physician. What we found was after 3.5 years of follow-up, there was a significant improvement in survival at 83% at that 3.5-year mark for the patients who got blinatumomab plus chemotherapy versus 65% overall survival in the patients that were randomized to the chemotherapy only arm. We saw similar results for relapse-free survival, and the death rate was largely from relapse of disease. We saw no new safety concerns with the use of blinatumomab in this study. The patients that were MRD positive at the time of the randomization, we had originally planned to randomize them, but when the Food and Drug Administration here in the United States approved blinatumomab for MRD positive disease in March of 2018, we then assigned patients to blinatumomab if they were MRD positive. We did see a benefit for blinatumomab in the patients who were MRD positive compared to those who did not get the blinatumomab, but this was not statistically significant, largely based on the smaller number of patients. So based on this study, we feel that the blinatumomab should be utilized in patients who are MRD negative to reduce their risk of relapse. And we believe that this represents a new standard of care for these patients.